are non-modified. But then all these factors lead to a certain pathogenesis. I'm not going to repeat, I read about 4,000 articles on pathogenesis published during last 20-25 years, including in JBJ's few years back. All these, the sum total of this research has been that osteoarthritis is no longer just wear and tear. It is chronic low-grade inflammatory disorder which is slowly progressive and has an immune-mediated pathology. There is local and systemic inflammatory process. So osteoarthritis, therefore, is a local manifestation of a chronic systemic disease. Osteoarthritis and rheumatoid arthritis, two ends of the same spectrum of disease process. Only thing is in osteoarthritis, tests are negative. The inflammatory markers are not raised that much. So what should be the treatment? That should be no-brainer. If it's a local manifestation of systemic disease, treatment has to be local as well as systemic, like we do for tuberculosis. So local treatment has two components: biological to target the inflammation and mechanical to correct the malalignment and deformity. The biological treatment used being around the world, you have seen all this in last 2 days, yesterday and today. All the orthobiologics, autologous, allogenic and ozone, they are all proven and giving fairly good results. Mechanical local treatment has established conservative wedges and braces, physiotherapy, osteotomies variety, and then total knee replacement. And of course, a new implant recently approved by US FDA a few years, 2-3 years back, has shown good promising result. Medially implantable shock absorber which jacks apart tibia and femur on the medial side, avoids rubbing and helps restoration and regeneration of the articular cartilage. Systemic treatment. Now, lack of positive diagnostic tests have usually deprived the patients of appropriate treatment for so long. However, in last 20 years, it has been shown in literature in variety of journals, osteoarthritis is amenable to wide range of DMARDs which are normally used for rheumatic diseases. Only thing is the dose, frequency, exact combination and duration of these DMARDs is being worked out, not yet fully globally centralized. Now, out of all this maze of variety of possibilities, how did we pick up? What should we do? It took us 2-3 years. And now we have standardized our protocol, including local treatment and systemic treatment. The local treatment, as I said, apart from physiotherapy, has two components, biological and mechanical. Now, our local treatment includes knee lavage with 1 to 2 liters of ozonized saline to flush out the inflammatory markers and the enzymes and the debris. Hyaluronic acid, high molecular weight, single dose, growth factor concentrates and ozone injection, 3 doses. Mechanical treatment depending on severity of deformity, heel wedges, braces, and the new thing that we are doing, which is propagated by Professor Jignesh Patel, very close friend of mine, the needleplasty, pie crusting of anterior 1/3 of superficial ligament and pes insignis, and I will show you how we do it. And now this local protocol has not evolved only over 3 years. We have now standardized it. It is 40 years it has taken for this treatment to evolve, because 40 years back we started with knee lavage when arthroscopy was just introduced. There were reports that knee lavage itself alone can improve symptoms for some time. Arthroscope was not with us at that time. We used to put drip in the knee joint, saline drip, and inflate the knee and then irrigate the knee and take out with aspiration, with the syringe. We were doing that in 80s. Then next decade we added arthroscopic debridement, hyaluronic acid and TKR came next decade, which continued for another 2 decades. Only thing is that the surgical debridement was abundant because it hastens the process of degeneration in osteoarthritic knees. And last few years, to local knee lavage and hyaluronic acid, we added first PRP, but very soon we replaced it by growth factors because of various reasons, added ozone and of course needleplasty. And the TKR is now very judicious. This video shows saline is being ozonized in the saline in that bowl. Now local anesthesia on the supralateral portal skin and diluted local anesthesia inside the joint to give the joint block, and then add arthroscope, do the wash with 1 to 2 liters of saline, and last bit of 500 ml of saline we add antibiotic also to make sure antiseptic is being done under IV antibiotic cover. And then we take this out, suture it, and then inject the hyaluronic acid, and then after this we do needleplasty. Essentially, simultaneously, the growth factor concentrates are being prepared. We use a double spin method without using any chemicals. And this is the growth factor concentrate that we have taken out, injecting the growth factor concentrate. And then you can see the ozone being drawn through the ozone generator, and medical oxygen cylinder is there. This is medically ozone 20 ml, 53 microgram per ml, and that is it. It takes about 20 to 25 minutes for the whole procedure. Now the needleplasty, how we do, as propagated by Dr. Jignesh Patel, local anesthesia for needleplasty, and then we do pipe crushing with 18 gauge needle. And I'll show you the X-ray. This is the lying down X-ray. You can see the lying down X-ray. Standing will be bone to bone. Now this is the pipe crusting being done, and then valgus thrust, and then you see the X-ray. See how beautifully it is realigned, and we maintain this with braces and physiotherapy for regeneration to happen. Friends, if the patient is so late coming to us, of course, TKR is the answer. Deformity, bone resorption, loose bodies, TKR. We do it judiciously, along with systemic treatment if necessary. Now, the systemic treatment that we use is low dose, low frequency DMARDs, along with their followed by their mitigating agent, treatment of other comorbidities, metabolic imbalance, osteoporosis, and lifestyle changes. Now, this, we have to be careful that we don't promise any miracle. We can only improve quality of life. We cannot prevent aging, and we need to be careful about that when we counsel the patient. This is the dose and principles, which is, most popularly known as Mukherjee regime. Very close friend of mine for last about 35 years. And he has longest experience. We have been using it bits and bits here and there. But after listening to him, now we have adopted his doses, but it has to be customized for each patient. Each patient's treatment is different. The different stage of disease, the treatment is different. So systemic treatment has to be customized to the needs of the patient, and it has to be personalized, and it has to vary from time to time, from patient to patient. Friends, after this has been standardized over last 4 years, in last about 20 months, we have used 120 knees with more than 96% absolutely very satisfied, and about 2.5% partially satisfied but better. Only one patient who did not complete the treatment converted to TKR. Otherwise, everybody has been very happy till now. Longest follow-up we have got 4 years. I'll show you that X-ray. After we have added ozone since last 6 months, the results comes within days or two, 1 day or 2 or 3. Now this is the patient with longest follow-up. Bone on bone, after 2 years, complete restoration. Just 1 minute more, please. Complete restoration, and you see the regeneration of cartilage and restoration. She was wheelchair bound, now fully active, running around, all activities of daily living, no pain, no painkillers. Now this is another patient, was on bed for 1 year, could hardly walk. She was unfit for total knee replacement because of comorbidities. She asked us to try our treatment on her, grade 4, and this is how she walked after 2 months. No painkillers, climbing stairs, doing all activities of daily living, happy with her family, out of bedroom, going on holidays. Friends, I believe that if we propose any new treatment, any new therapy, it should fulfill certain criteria. And that is, it should be simple and affordable. It should be minimally invasive and safe. It should be effective, long-lasting, induce disease remission, and should be evidence-based. Results should be reproducible, and there should be regulatory compliance, as my previous speaker has also mentioned. And most important, it should not worsen the symptoms. That is, there should be zero complication. And our protocol, we believe, till now has ticked all the boxes correctly. Thank you very much.